Good evening. There are goodies down here. Now I'm curious to see what's in this little bag of tricks down here. My name is Tim Gibbs, Executive Director of the Delaware Academy of Medicine and the Delaware Public Health Association. Thank you for coming to the second session of Delaware Mini Medical School, held here at the John H. Ammon Medical Education Center at Christiana Hospital. Mini Medical School is a partnership of the Academy and Christiana Care. We're delighted that you are here this evening. Last week, we went through all sort of the ground rules and whatnot. The one thing I will reaffirm to you all, please hold your questions until the end. Anyway, this evening our speaker is Janice Anderson. Janice is the manager of the Cardiac Rehabilitation Secondary Prevention Department at Christiana Care Health System, a program that focuses on optimizing safe exercise and risk factor modification in the cardiac patient. She began her career as a cardiac step-down unit nurse, where she assisted in creating and initiating a cardiac rehabilitation program. She transitioned into cardiac intensive care nursing and ultimately returned to her passion as a cardiac rehabilitation nurse. Janice participates in the Million Hearts Cardiac Rehabilitation Collaboration and is a member of the National American Association of Cardiovascular and Pulmonary Rehabilitation, which is the AACV-PR. There will be a test on that. And the Tri-State AACV-PR. Janice Anderson.
Thank you, and good evening. I'm going to be talking about the benefits of cardiac rehabilitation tonight. And what I titled my presentation is Get Pumped Up About Heart Health. But I want to pose a question to you, and I hope it's a rhetorical question. But if you had a loved one who experienced a heart event and survived that heart event, would you want them to have an opportunity to empower themselves to prolong their life and to have a better quality of life? And I hope the answer is yes. And the answer would also be cardiac rehabilitation, because that's what we do, is we help to empower our patients to take control over their disease and to have productive lives. I am going to start out with statistics tonight, and then I'll move over into anatomy and physiology of the heart. It's good to have that foundation. And then we'll discuss some of the diagnoses that can come in for cardiac rehab and what exactly those diagnoses entail. We'll move into cardiac rehab. What are some of the statistics, some of the information about cardiac rehab and why it's such a beneficial program? And then we'll talk about what exactly does happen in cardiac rehab. The statistics: heart disease remains the #1 cause of death in the United States. Heart disease accounts for 1 in 7 deaths in the U.S., and that equates to about 367,000 people that are killed each year from heart disease. Approximately every 40 seconds, an American will have a heart attack. The estimated direct and indirect cost of heart disease in 2013 to 2014, that average for that annual was almost $205 billion. So, to move into the anatomy of where exactly is our heart. The heart is actually about the size of our fist. So if we make a fist, that's about the size of what our heart is. And it's kind of about the same shape as what our fist is. It sits in our upper chest, and we have our ribs that surround it to protect it. And also on each side are the lungs, the spinal cord's in the back, and then the diaphragm is on the bottom. And that particular cavity, that area of your body, is called the thorax. Now, when we look at the anatomy of the heart itself, I'm going to primarily look at 4 of these, the chambers more so. But we do actually have our veins, our inferior vena cava and our superior vena cava, that bring the blood back up into the heart. And then we've got the top chamber, which is right atrium. We have the bottom chamber, which is the right ventricle. We have the top left chamber, which is the left atrium, and then the bottom left chamber, which is the left ventricle. In addition to that, we have doors throughout our heart that shuttle the blood through our heart. They're called valves. We have our tricuspid valve, we have our pulmonary valve, we have our mitral valve, and then we also have our aortic valve right there. And those are the areas that I'll be talking about the most, in addition to the aorta, which is where that aortic valve opens up its door and pushes the blood into the aorta, which is our largest artery in our body, and that is from where all the rest of our our oxygenated blood is disseminated from. But it is important to know about the electrical system, because we need to, our heart is like the engine of a car. Its purpose is to be a pump. We need to be able to pump oxygenated blood throughout our body. That's what the heart's primary purpose is. But in order for it to work, it needs to have an electrical system to have it work in a proper manner. And what happens is we have the SA, or the sinoatrial nerve, which is number 1 noted on this picture, which initiates an impulse. That impulse goes down into the AV node, or the atrioventricular node, and then it goes down further through the Purkinje fibers, and then ultimately it goes down into the ventricles through the left bundle branch block and the right bundle branch block. And what that does is it initiates the squeeze of the heart. It has the top piece of the heart in unison will squeeze, and then the bottom parts of the heart, the 2 chambers at the bottom, will squeeze. So the top 2 chambers, the atria, and then the bottom 2 chambers will squeeze in that manner. The EKG actually shows what is going on inside of our heart with our electrical system. And when you see this first wave, the P wave, what that actually is when that top part, that ventricle of the atria, the top 2 chambers, are squeezing and pushing the blood out. The next big lump, this one's called the QRS complex, is actually when that bottom one squeezes the blood out. And then we see the T wave, and that's where the heart's relaxing. So that's what we look at when we're looking at an EKG. Every single heartbeat should have that first lump, that's where the top is contracting, then it has the next lump, which is when the bottom part of the heart is contracting, and then it has the part where it's relaxing. So that's what we'd like to see in every heart. And this is one of the little things I brought in with me today. I don't know if everyone can see it, but this is a representation of what it would look like if our heartbeat was beating normally. You'll see that the top part gets the impulse, then it goes down the middle, and then goes to both sides of the ventricles to give that good squeeze, that electrical squeeze to get the blood out. Now, what can happen is we have a lot of different types of irregular heartbeats that we can get. And sometimes that top piece just kind of does its own thing, and every once in a while you get a good squeeze from the bottom. And that's called atrial fibrillation. And this is an example of what atrial fibrillation would look like, where you can see it kind of does its own thing, and then every once in a while you'll get that good squeeze at the bottom that comes out. And that's what, and in that particular case, when we looked at the EKG, what we would see was quite a few little P's, and then we would get the big QRS. So that's how we were able to identify that one. Now, how exactly does the heart work? Well, as we talked about, the heart's purpose is to be a pump. We need to pump oxygenated blood throughout our body. It needs to give oxygen and nutrients to everything. From the bottom of our feet to the top of our head, we need to be able to supply oxygenated blood for our body to survive. And what happens is our arteries will deliver oxygenated blood. And I talked a little bit about the vena cava. Those are the veins that bring the unoxygenated blood back up. And here for our diagram, the blue indicates unoxygenated blood. So the blood comes up without its oxygen. It's delivered the oxygen. It has some carbon dioxide. It's collected. It wants to get rid of it when it gets up here. So the blood will come into the right atrium. Then the tricuspid valve will open. and it'll go into the right ventricle where the pulmonary valve will open, pulmonic valve will open, and then it goes into the lungs. In the lungs, it gets the oxygen that it needs, and then it returns it back up into the left atria. It goes through the mitral valve, and it delivers, goes into the left ventricle, and then it is delivered into the aorta, where it goes to the rest of your body, delivers oxygenated blood. Our arteries are what's carrying our oxygenated blood, and that's represented by the red. And if you've ever had blood drawn, you'll notice when they take it from your vein, it's rather dark. It's not bright red, it's rather dark. It's a really dark red, and that shows that it's not oxygenated blood. It's coming from your vein. Sometimes we'll do something called an ABG. We'll want to check your blood gas from your artery. That one's going to be red because that does show that there's oxygen within that blood. And what's interesting too, if we cut ourselves and the blood seeps out, it's going to be red because it's hitting the oxygen of the air. So we will find that oxygen does make our blood red. So now what it needs to do is this pump needs to pump the blood everywhere in our body. And this is just a representation of how it goes through the lungs, comes back down through the heart, and then ultimately it delivers that blood to the rest of the body. Now, just like the heart needs to have, just like the rest of the body needs to have oxygen, your heart needs oxygen. How does your heart get oxygen? It's through the coronary arteries. And they actually lay on top of your heart, kind of like fingers just laying there. And then they dive deep into your heart to deliver that blood. We have three main coronary arteries. We've got the right coronary artery, we've got the left anterior descending, and then we have the left circumflex. We also have this small area here that's called the left main. And if you've ever heard of somebody talk about the widowmaker, they're usually referring either to the left main or to the top part of the LAD, because if you actually have a blockage, it's very quick and abrupt to those areas, you've shut down a lot of blood to your heart, and it's a very good chance you won't survive, especially if you're in that left main area. Sometimes we will do a stent in the left main, but almost always if you have left main, that means you're going to have bypass surgery. So who can participate in cardiac rehab? Well, we really follow what Medicare's guidelines are because most commercial insurances will follow what Medicare guides us to accept. But some insurances that are commercial insurance will allow a few other diagnoses as well. But recent heart attack, coronary artery bypass surgery, I don't know if you've ever heard this nickname, but we do call it a cabbage if you've had a coronary artery bypass graft. Heart valve repair, heart valve replacement, heart angioplasty or stenting, heart or heart-lung transplant, stable angina, compensated heart failure, and then some commercial insurances will look at additional diagnoses. We've had patients with a tumor that needed to have those removed and so forth. So indeed, some commercial insurances would cover that. So to explain a little bit about these diagnoses, what is angina? Angina, or angina as it can sometimes be pronounced, usually occurs when a narrowed coronary artery can't deliver enough oxygen-rich blood to the heart muscle. And these arteries can be narrowed most typically for these three reasons. Atherosclerosis, which is the hardening of the arteries and the buildup of plaque inside the arteries. Blood clots, we can get, and I'm going to go through a little bit more with blood clots in a little while, but we can get plaque that can be a little irritable and fragile and can allow a blood clot to form on there. And then also spasms of the artery. And I like to compare spasms of the artery like when you get a spasm in your calf. Your artery can just spasm and just stay tight for so long that by the time it relaxes, you did have some discomfort. What are the symptoms of angina? Well, it can be chest discomfort, chest tightness, chest fullness, chest burning, chest pain, chest squeezing or pressure, indigestion, shortness of breath, pain felt in the neck, jaw, arms, shoulders, or back, extreme fatigue. It can be any combination, or it could just be one of these signs. Most of the time, we consider the classical heart attack sign is the elephant sitting on the chest with the pain going down the left arm. But it can be in any way. My own father, he just had extreme fatigue and had a cold sweat. I had a woman one time in cardiac rehab who had jaw pain and was going to see her dentist, and it turned out indeed that was her angina and she needed to have a stent placed. So it can be a variety of symptoms that can happen, and a cold sweat. What do you do if you have angina? Well, the first thing you want to do is stop and rest. So you want to sit down or lie down. If you're driving a car, you want to pull the car over to the side of the road. If you happen to have nitroglycerin, if your doctor has prescribed nitroglycerin with you, you should carry it all the time with you. You want to place one tablet under your tongue, or if you have spray, put a spray under your tongue, and give that about 3 to 5 minutes to work. If you don't have complete relief, even if you've had some relief, but you don't have complete relief, we say call 911. We want to get them moving because it seems like maybe they should be giving you some attention. And you want to put another nitroglycerin under your tongue, whether it's a spray or a tablet. Give that about 3 to 5 minutes to work. And if you still have discomfort, you take a third nitroglycerin. And then our anticipation is that the ambulance will have arrived and they will take care of you. It is of utmost importance that we have our patients call 911. That's so important. We don't want you to drive yourself to the hospital. We don't want a loved one to drive you to the hospital. Time is muscle. The faster you can start getting treatment, they can do an EKG while you're in the ambulance. They can start an IV. They can give you the medication that you may need IV. They can continue to start other IV medications with you. And if you need to have a shock, sometimes we need to be defibrillated because that the electrical system, as I showed you, sometimes that can go out of whack, and you may need to have a shock to get your system back into alignment. So it's so important to call 911 and have them start administering care right away. Plus, that gets you to the front of the line. When you walk in the door, they know, they call it a heart code, but they know a heart code's coming in the door and they know it's 3 minutes out. They're getting that room ready, and it's going to be ready for our patients as they come through the door. Now, with a myocardial infarction, if I want to explain to you what the symptoms are of a myocardial infarction, or I want to talk to you about what causes a myocardial infarction, I really can go right back to angina. Because the big difference between angina and a myocardial infarction is angina is temporarily not getting enough blood flow to a certain area of your heart. Whereas a myocardial infarction or a heart attack, it's the same thing. We call it an MI, but a heart attack and a myocardial infarction are the same thing. Can be caused by atherosclerosis, by blood clots, by spasms in the artery, but it's permanent. So whatever loss of blood flow that you had did cause some permanent damage to your heart. That's what the big difference is, and it's very significant. So I always like to compare it to putting a rubber band around the tip of my finger. If I put a rubber band around the tip of my finger and I leave it there for 5 minutes, well, what's going to happen? It's going to throb, it's going to hurt. I take that rubber band off, the blood goes back into the tip of my finger. I didn't cause permanent damage, but it really hurt a lot while I had it. If I put that same rubber band around the tip of my finger and I just don't take it off, eventually the tip of my finger is going to die off because it's not getting the oxygen and nutrients anymore. And that's the difference between angina and a heart attack. Now, angina actually can have something called stable angina. Stable angina is when you only get discomfort when you're doing an activity. The doctor needs to know it, he needs to assess it. Sometimes we have patients who have blockage so far down in their artery, it's not an area that they can get in and do any type of intervention on. But by participating in cardiac rehab, by exercising, not to the point where you get pain, to the point prior to getting any sort of discomfort, what we actually can do is those arteries that are on the outside of our heart, those coronary arteries, can actually start to provide collateral circulation. They can start to get wider and bigger and start to feed into areas that are having some trouble because of narrowing. So we can promote collateral circulation in our heart. But that is typically a blockage. It's just kind of gotten a little bigger and a little bigger over time. It's been a slow but steady increase in a blockage. Now, this is a picture of a heart attack, and it shows you where the blockage is in this circle. And now no longer is this area here getting any more blood flow. That artery now has been cut off, so it's no longer getting blood flow. So that is going to cause a permanent damage. What happens? We talked about the spasms, and some people do get spasms in their artery, and those are patients that we put on a calcium channel blocker to help prevent those spasms. We also can have the gradual narrowing of our arteries, and maybe even a piece of plaque is cracked off from somewhere and now has wedged into that narrowed area and has caused a loss of blood flow to that area. Those are common ways that a heart attack can happen, but by far the most common way that a heart attack can happen is rupture of the plaque. And the plaque has a little bit of skin almost over it. They call it the fibrous cap. And that can get inflamed, it can get irritated, and it can crack. And when it cracks, the body doesn't discern, I shouldn't go heal this. I shouldn't go make a clot and heal it. Because it's almost like when you scratch your hand. Your body's going to make a clot to heal that hand. Your body wants to go and make a clot over that area where the interruption has happened. And that's the worst thing you want to have happen, because that clot's going to go in there and it's going to cause a blockage, and the blood's not going to get beyond that point. Doctors will put patients on aspirin because the anticipation is, should that plaque crack and blood seep out, instead of forming a clot, it's just going to let it wash away and not allow the clot to form. But this is by far the most common way. They call it an acute coronary syndrome, ACS, and sometimes if we can get to it fast enough, it's not a heart attack. It's just an acute coronary syndrome that didn't become a heart attack, but it also very commonly can become a heart attack. So what will happen is when you get to the hospital, they'll do a few studies. And I really just focused in on the ones that would be most pertinent specifically to the heart. But they're going to do a physical assessment. They're going to check your vital signs. They're going to listen to your heart. They're going to do blood studies. They're going to look to see, did you spill an enzyme in your blood that would indicate that there's been some damage to your heart. And they're going to do an EKG. And when they do the EKG, what they're going to look for is, are you having an ST elevation? This is a normal heartbeat. Remember, we talked about the P wave, the QRS, and then the ST segment. Well, now this is what we call a fireman's hat. This is an elevated ST segment. That is significant for an infarction. That means there's been a permanent loss of blood flow. If you have an ST elevation, you've had a heart attack. And they call that an ST elevated MI, heart attack. Now, sometimes people get ST depressions, and that can happen when we do a stress test to see, hey, are you having any sort of problems? When you have ST depression, that indicates what we call ischemia, or a loss of blood flow. But it's not specific for an infarct. It's just showing that there's a loss of blood flow at that time. So what's a typical treatment that they're going to do when you come into the hospital if you're having a heart attack? Well, they can do thrombolytic therapy. They call that the clot buster, where they can give you medication that will break up that clot. They also can do percutaneous coronary intervention. There's a couple things, there's actually a few things, but I'm going to focus on two things primarily that they'll do. They'll do something called a percutaneous transluminal coronary angioplasty, a PTCA. Dr. Dory brought that to us here at Christiana Care back in 1987. That's when they go in with a balloon and open up the blockage with a balloon. Then there's the next one that goes a step further. It's actually stenting, and that's putting a wire mesh about the size of a spring in a ballpoint pen over top of the balloon. And what they'll do is they'll take the patient in for a cardiac catheterization. They'll access either their radial artery, or they'll go through their groin, and they'll take a tube and put it up into the heart. And at the end, there is that balloon. And when they go into the area where the blockage is, what they're going to do is they're going to inflate that balloon, and it's going to compress that blockage to the side of the artery. This is a picture of what happens when they do it with the stent. They have the stent on top of the balloon, that wire mesh. They go in, they inflate the balloon. It now deploys the stent, and then they deflate the balloon and pull it right back out again. Now that stent is like scaffolding. It's keeping that nice and wide and open and keeping that plaque compressed. Over time, that stent will just become part of the body. They'll have a light layer of skin that will grow on top. But initially, they're going to put our patients on some type of antiplatelet therapy, Brilinta or Plavix, Effient. Those are different medications. And then the cardiologist, depending on each individual, may choose to have that patient on that medication forever, or may only want them on that for anywhere between 3 months to a year. It just depends on each individual what they would like to do. Now with coronary artery bypass graft, remember I said those arteries lay on top of your heart, so they're really easy to get into. They're really easy to for the surgeons to address. What they do is where the blockage is, they do exactly what they say. They bypass it. They jump over it. So if you have an area of blockage, say right here, what they can do is take that either a saphenous vein graft from your leg, or they can take a big internal mammary artery. They can redirect it in your body to supply blood below that point. And sometimes they'll even use a little piece of your arm too. But most commonly it's the saphenous vein graft and the mammary arteries. And what they're going to do is go right below it. So if this is where the blockage is, they can actually jump it right over here. If that blockage completely fills in, it's not a problem because you're now still giving blood flow beyond the point where the blockage was. So that's how they're able to do bypass surgery. Now, there's more than one way to do bypass surgery now. There is a traditional way, but we've also got minimally invasive and robotic open heart surgery. Well, not necessarily open heart, but surgery to do those bypasses now. And then we can look at valves. Valves are also very important. We talked about how they were the doors, and they help to make sure that the blood shuttles properly through the heart and makes it an efficient pump. Well, this is what a normal aortic valve would look like. But then there's one that's called stenosis. We can see stenotic valves. And what happens is they just get rigid. They're not flexible. They just get, they don't open well. They don't close well. They're just not very efficient. And then there's regurgitation. And regurgitation, it just never closes right. So with aortic, with the stenosis, it's hard for the blood to get through those tight areas and to really adequately fill the chamber as needed. With regurgitation, it's hard to adequately fill the chamber because it sloshes back into the chamber above. So it doesn't allow for an efficient pump. So that's what happens with regurgitation. So we have a few treatments as well in those cases. We can do a repair of those valves. We can actually put replace the valve either with a biological valve, which is usually from either a pig or from a cow, or we can use a mechanical valve. The difference, mechanical valves, you actually have to be on medication. You have to be on a blood thinner if you have a mechanical valve. The biological valve, you don't need to be on a blood thinner. The lifespan, they're constantly doing wonderful things, but the lifespan is generally longer for a mechanical valve. So, and then we also have something called TAVR, where we're able through a catheterization to be able to replace a valve. Usually, in our case, we do the aortic valve that way here at Christiana Care, but we usually do it for somebody who would have a tough time with surgery. It's usually generally somebody who's maybe a little more debilitated, and we don't want to see them have to go through an open heart surgery. Then there's something called heart failure. And there's a couple types of heart failure too. There's a diastolic heart failure. And what that is, and sometimes we call that the preserved ejection fraction, but that is when the heart just can't fill. This chamber is so small now. This is that left ventricle, and it needs to be strong. It needs to have a good muscle that can pump that out through the rest of the body. It's going to go through that aorta and supply blood everywhere. But that can get stiff, and it can get thick, and just not allow as much blood to fill into that. So even if you're having a good ejection fraction, it's not really. An ejection fraction is how much the percent of the blood gets pumped out. It's really not that good because it's not a large volume that's getting pumped out. And then what we see in cardiac rehab, we're allowed to, Medicare has approved for systolic heart failure to come into cardiac rehab. And that's when the heart is just stretched so thin, and it just isn't an efficient pump. It's overstretched, it's boggy, it just can't give a good squeeze. And what can cause this is high blood pressure is a huge component in that. Blood pressure, if you think of our heart as being a pump and you need to pump it everywhere, if our arteries are already full, they're already high blood pressure, we're pumping against resistance like that, and that's going to wear down the heart. So that's one of the big ways that systolic heart failure can happen. A heart attack can cause that. A virus can cause that. Chemotherapy can cause that. So there's different reasons why people can have a weaker heart pump, but high blood pressure is a huge risk factor for that. And what can we do if you do have heart failure and your heart's just really wearing out? Well, there's a few choices. Ideally, you'd be able to get a transplant. That would be awesome. Sometimes not everybody can get a transplant. Sometimes there's just not a heart available. They're very specific to sizes. We've had extremely tall people that have struggled 6'8" to find a heart that would be their size. Sometimes there's just other risk factors that won't allow them to that won't allow our patients to get a heart transplant. Maybe they're overweight. If you're too heavy, you can't get a heart transplant. So there are other options, and we actually here at Christiana Care do something called a left ventricular assist device, and that's a mechanical heart, and that can take over the workload of your heart. What we use here is a HeartMate 2, and you can hear a steady hum. You don't get the pulses that you do with blood pressure because it's not pumping like that anymore. It's just a steady hum that's sending the blood out. And we've seen some wonderful situations where we've seen people that have had to have that in for a short period of time, and ultimately were able to have that removed and have their heart work normally again, which was fantastic. And some people use it until they can get a heart transplant. And some people, that's just what they're going to have for the rest of their life, is they're going to have a mechanical pump that's going to allow them to enjoy life for a longer period of time. So if I ask you about what is cardiac rehab and secondary prevention, most people would say it's an exercise program. And you know what? That's right. We are an exercise program, but we're also a whole lot more. I'm going to tell you a little bit more about what brought us to where we are today. Back in the 30s, if you had a heart attack, you were on bed rest for 6 weeks. Then we found out, you know what? If you're on bed rest for 6 weeks, you get blood clots, you get pneumonia, you end up getting sicker. So in the 1940s, they started saying, let's start and get people up and moving, some light activity. And then in the 50s, they started getting a little bit more structured. Let's give 5 minutes a day of a daily walk when you're four weeks after your heart attack. Then in the 1960s, they started an inpatient program where after somebody had had bypass surgery or some sort of a heart attack, they would get them up and walk them and make sure that they were comfortable. And then in the 1970s, outpatient cardiac rehab was formed. 1980s, we evolved. And now we realized it wasn't just exercise. We needed to talk about lifestyle modification. We needed to look at what the risk factors were that brought our patients in. And then in the 1990s, we were validated when we got our first clinical practice guidelines for cardiac rehab. And that broadened our scope. So Again, when I say what is cardiac rehab and secondary prevention, because we've now added, and I have to say I call it cardiac rehab all the time, but its real title is cardiac rehab and secondary prevention. What is it? It's a patient-centered, comprehensive, multidisciplinary secondary prevention program. When I say patient-centered, that means each person is individualized. Nobody is held to the standards of the person next to them. It needs to be what that particular patient needs. Comprehensive, with the knowledge that there's many things that impact us. We're not just working with your heart. We're working with your body as a whole. If your lungs aren't working well, that's going to be a problem. If you have a problem with your skin, if your incision's not healing properly, that's going to be a problem. If you're under a lot of stress, that's going to be a problem. We look at the entire person. And it's multidisciplinary because we know that no one person can be an expert at everything. So we're fortunate to have exercise staff, registered nurses, clinical psychologist, our medical director, smoking cessation counselor, registered dietitians, pharmacy liaison. So we're very fortunate to have a very comprehensive program. And secondary prevention, what does that mean? Well, secondary prevention is when we're trying to find that disease at its earliest stage and stop it. We want to detect it and we want to stop it. And by managing our risk factors is one of the ways that we can do that. So what are our goals for cardiac rehab? Our goals are to provide empowerment to our patients so that they can understand heart disease and what can be done to control it. We like to make sure that our patients know their numbers, they know what their blood pressure is, they know what their cholesterol levels are, they know what their waist circumference is, what's their BMI. But more than just knowing that you have numbers, know what those numbers mean. And we also provide a safe, controlled atmosphere with a staff of healthcare professionals. And we help patients optimize their physical abilities and improve their quality of life. Now, there's been a lot of studies done about cardiac rehab. And what they found is there's 3 times the likelihood of readmission for our bypass patients who did not attend cardiac rehab. There's a 46% 10-year relative risk reduction in all-cause mortality, that means death, due to participation in cardiac rehab following bypass surgery. 25 to 31% reduction in hospital readmissions for those who participated in cardiac rehabilitation. 31% decreased number of days with their rehospitalizations if they participated after an MI or a bypass surgery. And then a 45 to 47% reduction of all-cause mortality after having a PCI, which is either a stent or an angioplasty. Medicare did some research too. And what they found is if a patient came to one session of cardiac rehab, one session, there was a 14% lower risk of death, and there was a 12% lower risk of a heart attack. If they came to 12 sessions, there was a 22% lower risk of death and a 23% lower risk of heart attack. And if they came to 36 sessions, which is what Medicare recommends, there was a 47% lower risk of death and a 31% lower risk of MI. So there is a correlation to the volume of sessions. Now, cardiac rehab is considered a Class 1A treatment. What that means is it's an expectation of care. After you've had a heart attack, after you've had any sort of intervention like bypass surgery or stenting or PCI, our patients who have experienced those should be referred for cardiac rehab. It's just like they should get aspirin, they should get a beta blocker, they should have an ACE inhibitor, they should participate in cardiac rehab. It is a proven therapy. But unfortunately, we just don't see the same investment out there. About 56% according to the American Heart Association, get with the guidelines, actually were referred to cardiac rehab before they were discharged from the hospital, compared to 84 to 98% that were given the medications that were recommended. Now, what happens in cardiac rehab? We have 3 phases. Phase 1 is when you're in the hospital. After you've had a heart attack, we mainly monitor if you're independent and you're walking well on your own. We may just monitor what your exercise is and see if there's any assistance that you need from us. But if you've had bypass surgery or you've had a valve replacement, if you've had heart failure and you need some assistance with walking, actually we'll be the first person that takes you for a walk after you've had surgery, almost always. And then there's phase 2. That's our outpatient program. And I'm going to go into that in just a couple minutes. And then there's phase 3, which is maintenance, just continued exercise going forward. So the overview for our inpatient program, we actually have order sets. Because it is a standard of care, the doctors, it's automatically on the order sets that you should participate in cardiac rehab if you meet those specific criteria I just talked about. So our inpatient staff is going to provide the following services. They will assess and assist with activity. They evaluate the need for discharge oxygen support and for any sort of assistive devices with ambulation. And they provide the patient and family with discharge instructions and education for safe activity guidelines. They've got a few programs that they're going to evaluate the patient and see which program is the best program for exercise at home. And then they're going to refer the patient to an outpatient cardiac rehab. And it may not be Christiana Care. Maybe somebody lives down by Bay Health, or it may be somebody that lives over by Salem. But we're going to make sure that we've connected our patient to a cardiac rehab program that would work for them. Because at the end of the day, it has to be convenient for you to be able to continue and to be compliant. We will look up Florida and find out, sometimes we'll have people that are up vacationing and they're going back home again. So we'll find a cardiac rehab. So what should you expect from outpatient cardiac rehab? Well, it is a supervised. We have everyone wear a heart monitor, individualized exercise program with integrated secondary prevention, education, and counseling. We provide case management, and this allows for interventions that may prevent rehospitalizations. It's not uncommon that maybe somebody will have a little run of atrial fibrillation that they didn't even know that they had. We're able to contact the physician. They don't need to be rehospitalized. They feel perfectly fine. They can go back in and see their doctor. Maybe he needs to look at their medications and perhaps add a medication. So we're able to make some interventions that can help to prevent hospitalization. And we also want to empower the patients so that they can understand and manage their disease after they've completed our program and actually while they're in our program. Our program is typically 3 days a week for 3 months. It totals 36 sessions, but we do tailor to individual needs. That 35-year-old that's going to be going back to work in a few weeks, we're going to look to see what can we do to make sure that we give them as much education as possible and that we monitor them and we progress them in their exercise levels that are going to be appropriate and safe, but allow them to return back into their working population. Also in outpatient cardiac rehab, what do we do? The first day our patients come in, we do an initial assessment. It's a very thorough H&P that's done by the nurse. We also do medication reconciliation. We'll double check what did they discharge our patients from in the hospital and what are they taking now. Sometimes there's a discrepancy and we want to clarify with the doctor, had there been a change since they came home from the hospital or did they misunderstand? Sometimes the family doctor may order a medication that's very similar to a medication that the cardiologist had ordered and the patient's not aware they should discontinue the one beta blocker because they're now on a different beta blocker. So we're able to review and intervene if that's a need. Also, we create something called an individual treatment plan. It's a care plan from the olden days. But what it does is it's really the story of the patient. It addresses and follows the goals, interventions, education, reassessments, and the final assessment on our patients for exercise, nutrition, psychosocial needs, and what we call other core measurements or risk factors such as diabetes and high blood pressure and hyperlipidemia and heart failure. So we do create that, and we know our patients really well through this. Then there's going to be an orientation to exercise. So when our patients come in the next time, we're actually going to have them exercise, and we're going to find equipment that works well for them. And then there'll be ongoing daily assessments. We're going to watch the heartbeat. Are there any funny heartbeats? Any pain, and it doesn't have to be cardiac pain. Did you get a muscle discomfort? Did you get a orthopedic discomfort? How's the blood pressure running? Is the weight staying stable? If you're diabetic, is your blood pressure staying stable? Any changes in your medications? And we're going to give education. And this is actually incorporated throughout the program. Nobody can just get, and although you guys are getting a whole bunch of education dumped on you at one time now, but in our arena in cardiac rehab, we like to give it to you in bits and pieces so that it's not overwhelming. We have an education packet that we give all of our patients. We have individualized and group education as well provided and evaluated. And we encourage our family and support people to participate as well in our education. We review that care plan, that individual treatment plan, at least monthly with our medical director on every single patient. In addition, with the cardiologist, the minimum amount of communication that we have with the cardiologist is when our patients start the program, midway through the program, and when they've completed the program. And we include some data that we've collected along the way so they can see what changes have been made. At completion of the program, we have collected that post data. We have given our patients an individualized exercise prescription. And we've also reviewed this care plan with our patients to discuss their achievements and their future goals. We're just a springboard. We know we're not the end of the path. We're just the beginning of the path. So we want our patients to feel comfortable and to continue to set goals after they leave us. Our exercise program is individualized to optimize functional capacity. And I do like to tell the story. At one time, we had 2 patients that were participating in our program at almost the exact same time. I had a gentleman who was about 85 years old who had had, I believe he had had a stent placed, and he needed to go into an assisted living for a bit of time before he could come home, an extended care facility before he could come home. After he came home, he didn't actually get to go back to his home. He went back to his daughter's home. When he came into us, he was able to walk on the treadmill for 1 minute at a time. And he set a personal goal for himself. When he was done with our program, he was able to walk for 10 consecutive minutes, which was awesome. And he was able to leave his daughter's house and return to his own home and be independent again, which was, of course, we used a lot of other pieces. It wasn't the only piece of equipment we used, but that was so important for him to be able to walk 10 consecutive minutes on the treadmill. At the same time, we had another gentleman. He was in his late 30s, early 40s. He had been an exerciser in high school, beginning of his 20s, but really had not continued on that path. Before he also had had a stent. Before he finished, 1 week before he finished our program, he completed his first triathlon. So we are definitely geared towards what is appropriate and what is safe for our patients to do, but what is going to optimize them and bring them back to the health that they need for their personal needs. So what we will do is we have an exercise prescription when we talk about our exercise part that follows the most recent American College of Sports Medicine, American Heart Association, our AACVPR guidelines, and it tailors that program to enhance and progress all levels of physical activity in a safe manner. We do get a lot of patients that maybe never exercised a day in their life, and we're able to initiate that. And honestly, a lot of times those are our patients that don't want to leave at the end. They had such a wonderful time and they enjoyed it so much. But we know that they have continued that once they've graduated from our program. We look at our patients, we look at their frequency, how many days a week are they exercising? We look at their intensity, are they doing moderate, high intensity? How long are they exercising? What type of exercise are they doing? Cardiovascular is what moves your large muscles smoothly and gets your heart rate up and your respiratory rate up, such as dancing and biking and swimming. We look at their volume of exercise, which actually takes into consideration frequency, intensity, and time. So that all plays into it. And progression. We want to see that nobody's ever stagnant. They add a little bit more time on. They make it a little bit more intense, but make small changes along the way that add to the progression. And we have a strong focus on incorporating safe home exercise and independent activity. We actually want our patients, after they've been with us for about a month, start integrating some exercise activity at home so that when they're done with our program, that it's seamless. They've already established a program and they're going to continue in a seamless manner. Now, what are the benefits then of cardiac rehab? What have been realized? The benefits are a combination of the cardiac rehab and secondary prevention components. Approximately half of the mortality, and that means death, half of the mortality reduction achieved by exercise-based cardiac rehab can be attributed by the reduction of the major risk factors. That education is so important in addition to the exercise. Other factors that may contribute to the benefits of cardiac rehab is the reduction of inflammation. Remember, we talked about how inflamed the fibrous cap can be over the plaque and how that can get irritated and rupture. So it helps with the reduction in inflammation, ischemic preconditioning, so that there's less potential for, so there's better blood flow, so there's better oxygenation throughout. And improved endothelial function, that's actually the artery, that artery is improved in its functioning. And there's a more favorable fibrolytic balance. That clotting is that the blood clots, the clotting is in a better place. Now we have 10 components for cardiac rehab that we have to adhere to. It is what cardiac rehab is all about. All cardiac rehabs have to look at these 10 components: physical assessment, nutrition counseling, weight management, blood pressure management, lipid management, diabetes management, tobacco cessation, psychosocial management, physical activity, and exercise training. And I think I'm going to ask you guys if you'd like to take a little break right now, and then we can get back into the completion of the lecture, where we'll talk about what we will do and what we have to offer more specifically in cardiac rehab and how it does impact our patients. So thank you. I'm going to talk about what we do in cardiac rehab, those 10 components that we touched base on. The very first day that you come into cardiac rehab, you meet a registered nurse. All our registered nurses worked in cardiac intensive care for many years before they came into cardiac rehab, so they're very well versed in cardiac care. And they're going to do a head-to-toe evaluation. They're going to listen to your arteries in your neck, listen to your heart, listen to your lungs, check your pulses, look to see if there's any orthopedic concerns. Do you have any incisions? Let me look at those. Let me make sure they're healing properly. So we really do a really strong head-to-toe evaluation, including blood pressure and heart rate, and look at we hook you up to the monitor the first day to see what does your baseline look like. What's your single lead EKG look like when you're with us? So that first time you come in is going to be with a registered nurse, and there will be a history and physical. We're going to review medications. We're going to discover what is your preferred method of learning. Do you like watching it? Do you like reading it? We're going to assess for any learning barriers. Is there any hearing deficit? Is there a language concern? Because we want to make sure that we can get that information to you in a way that you learn best. And together, we're going to create goals and plans to achieve the goals that we've created. There will be an RN that will case manage our patients throughout the program, and that includes a daily assessment. Every day, we reassess our patients when they come in. And we're assessing and reassessing educational needs, physician communication, and we teach the patients how to take control of the disease. We want them to understand how to self-assess and be aware of signs and symptoms and what to do. To move on to nutrition, this is just an example of what somebody who is not on restrictions, what a 2,000 calorie diet should include. Honestly, if you have had cardiac disease, your saturated fat should be 6 or lower. But this is just an example that you can find on just about any product that says what are the daily requirements that you should have for a 2,000 calorie diet and a 2,500 calorie diet. Then my plate is something that's taken the place of the pyramid. I don't know if anybody in here remembers the pyramid for how to eat properly. They've changed that now. It's now called My Plate. And you'll notice that the government's changed it to have half of the plate is fruit and vegetables, a quarter grains, a quarter protein, and then dairy. But universally, the diet that has been most accepted through the cardiac population is the DASH diet. And the DASH diet actually stands for Dietary Approaches to Stop Hypertension. But it's not just for patients that have high blood pressure. It's accepted as one of the best diets that's out there. It gives you guidelines as to how many grains and how many fruits and vegetables. Other good diets that exist are the Mediterranean diet. And I know patients that are vegetarians and patients that are on plant-based diets. Those are wonderful diets as well, if they're done properly. It is hard to maintain a good balanced diet, but they can be done. It just takes some real dedication and a lot of work. But universally, the DASH diet is one of the healthiest diets that exist out there. So what do we do in regard to nutrition counseling? We review eating habits at the start of the program, and we determine where changes can be made specific to risk factors. Different things can impact our diet. Are you diabetic? Do you have high blood pressure? Do you have heart failure? Do you have kidney disease? Because there are certain limitations that may be placed in there. We reassess eating habits at the end of the program, and we provide nutrition classes that are taught by a registered dietitian. Every month we have 3 outpatient locations. And at each one of those locations, we have a registered dietitian who comes and talks about heart healthy eating 1 day a week. And then we have a registered dietitian who comes and talks about heart failure nutrition once a week. Very similar, but slightly different. Heart failure, you really have to watch your fluid level and really keep a close eye on your sodium. And then nutrition topics are discussed in the exercise room to generate conversation. And there's always an opportunity for our patients to have one-on-one sessions with a registered dietitian. Now, our nutrition counseling is included in our program, but our one-on-one nutrition counseling isn't. We're able to provide that for you, but it may not be a covered benefit by your insurance depending on what your diagnosis is and what your plan will cover. Weight management is huge for cardiac rehab. All cardiac rehabs note that that's one of our biggest struggles, just to help people with their weight. We look at body mass index, and we also look at waist circumference. Now, body mass index, a normal body mass index is 8.5 to 24.9. And then from there it goes to overweight, and then obesity, and then extreme obesity. In order to calculate your BMI, you just take your weight, you times it by 703, and then you divide it by your height, and then you divide it by your height again, and that will tell you what your BMI is. What are the problems with being obese? Well, it can raise your blood cholesterol and your triglyceride levels. It can lower your good cholesterol, your HDL that you want to get high. It can increase your blood pressure, and it can induce other comorbidities like diabetes. In some patients, diabetes makes other risk factors much worse, and the danger of a heart attack is especially high in this population. Obesity also increases the risk for heart disease and stroke, but it harms more than just the heart and the blood vessel systems. It also can cause osteoarthritis and respiratory problems, gallstones. So what do we do with weight management? We get some information when our patients are first starting the program. We'll get their body mass index, we'll get a waist circumference, and we do rate your plate, the questionnaire that looks at what eating habits are. Then we're going to set realistic and reasonable goals if the patient needs to lose weight. Some of our patients actually are thin and would like to gain weight. So if we're looking to lose weight, we want our patients not to lose more than 1 to 2 pounds a week. And if you decrease 500 calories from your diet a day, in a week you'll lose about 1 pound. Nutrition counseling is provided. We establish a consistent exercise program, and we track progress by repeating these measurements at the end of the program. Now, what's interesting is we do waist circumference, and we also keep an eye on your weight. Sometimes weight may stay about the same, especially if somebody's had surgery. Their appetite may have decreased for a bit of time. Then their appetite's starting to come back again. They're exercising, so they're losing some weight, but their appetite's returned, so they're putting some weight on. But we measure their waist at the beginning of the program, and we sometimes, it's not uncommon, to find that even if their weight did not change much, they've lost inches off of their waist, because what they were doing is they were changing their body composition. If I could hold 5 pounds in my hands, 5 pounds of fat would be equal to about 1 pound of muscle. So you would have so much more dense muscle. I'm sorry. If this is 1 pound of fat, it could be about 5 pounds of muscle, because muscle is so dense and it weighs so much more. So we do like to keep an eye on that, but we also like to relish progress when maybe a weight doesn't change, but a body composition changes in a good way. Now, with blood pressure, we record 2 different numbers. So when we take your blood pressure, we have you seated, we have your arm heart level, we have your feet flat on the ground, you've rested for about 5 minutes at least. Didn't smoke, hopefully, at all, but at least not for a half hour before we took it. And your systolic blood pressure is after we have inflated that blood pressure cuff and we gradually let it go, it's the first bump that we hear. And what that is it's when the blood is getting pushed out of the heart and getting pushed into the arteries. That's that first bump. Now, diastolic, that's the lower number, and that's when we stop hearing the bump as we go down. And that's when the heart relaxes, when it's not pushing that blood out anymore. Now, we do keep an eye on both high blood pressure and low blood pressure in cardiac rehab. They changed the numbers recently, within, God bless you, the last year. Now, a normal blood pressure is less than 120/80. Elevated blood pressure is 120 to 129 and less than 80. High blood pressure, stage 1, is 130 to 139, or your diastolic is 80 to 89. And high blood pressure, stage 2, is 140 or higher, or 90 or higher. So they did tighten those parameters. And then hypertensive crisis is if your blood pressure is greater than 180 or higher than 120 diastolic. That's scary. That could cause a stroke to happen. So that's really scary to get your blood pressure up that high. If that happens, you need to let your doctor know immediately. But we also want to be aware of low blood pressure. A lot of our patients are on medications they hadn't taken before, and they can impact our patients' blood pressures. How low is too low? Usually we say if you're symptomatic, if you feel dizzy, if you feel lightheaded, we get a feel for what your normal is. But if you're less than 80, we're going to let your doctor know. But if your normal blood pressure is 120 and you come into us with 80, we're going to call your doctor immediately if that's where your blood pressure is. But typically, as long as you feel comfortable, your blood pressure is okay. But if you get dizzy, lightheaded, feel a little foggy, then it's too low and we need to make your doctor aware. And he may want to make some medication changes. Blood pressure management. Blood pressure medication dosages are directed by your physician. All we do is communicate with your doctor. He guides what your medication should be. Blood pressures are done daily. We review medications. We give education. Why do you take this medicine? How does this medication work? And do you take it consistently? And we also like to give the education about high blood pressure and low blood pressure and understanding what those blood pressure numbers mean. And we do communicate with your doctor if it's too high or too low. Now we're going to talk about lipids. That's our cholesterol. We have a few numbers that we look at. We look at the total cholesterol, which actually is a calculation of the good cholesterol, which is HDL, and the bad cholesterol. We add those together, and then we add 20% of the triglyceride level. We used to be really focused, and we had actual numbers that we wanted you to adhere to with cholesterol. That changed in about the past 2 years, where they have said, you know what, we're finding certain risk factors make you more prone to having heart disease. So we're not just going to look at numbers. We're going to look at a bigger picture. Do you smoke? Do you have high blood pressure? We're going to add other things. Are you diabetic? Those are some things that even if your cholesterol levels were fairly normal, may guide the doctor to consider adding in a cholesterol medication, a statin of some kind. So our high-density lipoproteins, HDL, we say think healthy when you hear that. The higher you get that, the better. It's kind of like it's like a beach ball. It floats around inside your artery. It grabs some of the bad cholesterol, takes it back through the liver, and gets rid of it. Now, the low-density lipoprotein, think lousy. That's the bad stuff. That's what actually makes these blockages. We believe that's what contributes to that fatty buildup in the arteries. So we do like to see that low. And then triglycerides. They're the most common type of fat in the body. We used to say we want to see that 150 or less. And they store excess energy from our diet. High triglyceride levels combined with a low good cholesterol or a high bad cholesterol is linked also with fatty buildup in the lining of the arteries and increases our risk for heart attacks and stroke. Triglycerides are impacted somewhat by carbohydrates. So if you have a strong sweet tooth, if you're diabetic, if you drink alcohol, more large amounts of alcohol, you may see that you have high triglycerides. Lipid management. So what do we do? Well, again, the cholesterol medication dosage is directed by your physician. We review medications and we give education regarding those medications and how they act and ensure that they're taken consistently. We do still get cholesterol levels, though. We still look at numbers. We just look at them in a broader scope. So we get numbers when you first start, and then we get your cholesterol numbers when you're all done. And again, we want to review what do those numbers mean and what can be done to improve your lipids. Now, what is diabetes? I did research recently, about 25% of our population in cardiac rehab is diabetic. Diabetes is a chronic disease that happens when the body can't make enough of the hormone insulin in the pancreas, or it can't properly use the insulin that it has. And insulin's necessary because it helps the body digest sugar that comes from our food and our drinks, and then we use that as energy. Without enough insulin, that glucose is just going to build up in our body, and over time it's going to cause damage to our nerves, our blood vessels, our heart, our kidneys. We've noticed that some people will get neuropathy in their feet. One thing about diabetics, sometimes they don't feel chest pain. They've got some neuropathy there. They just don't feel chest pain. There's a couple different types of diabetes. So there's type 1 diabetes, and that's the one where the pancreas just doesn't work anymore. We used to call it juvenile diabetes because it was just that the pancreas stopped working. Only about 10% of the population has type 1 diabetes. But type 2 diabetes, that's the one where the pancreas just isn't able to work appropriately anymore. And that's what about 90% of the population is type 2 diabetic. And the unfortunate thing, and why we no longer call it juvenile onset and adult onset diabetes, is we're finding children are being diagnosed with type 2 diabetes. And I think we all know that our activity level has decreased, our consumption of food is different now. We eat more on the go and not always the best prepared. We don't always have recess anymore. Kids don't get gym as routinely as they used to, and it has negatively impacted. What do we do with diabetes management? Well, again, our diabetic medications and dosages are directed by the physician. We check blood sugars before and after exercise if you're diabetic. If you're an oral controlled diabetic, we'll check you for the first couple weeks. If it stays steady, we'll just check you every once and again. But if you're insulin dependent, we want to check you every time you come in. We want to give education, blood sugar monitoring and frequency, signs and symptoms of low blood sugar, signs of high blood sugar, medication, diet. We may refer to a registered dietitian. And there's a Living with Diabetes program that was at PMRI and will be returning, I believe, once we reopen there. And we will communicate with the family doctor, the endocrinologist, with any concerns or abnormal results. And we work a lot with that. We see a lot of our patients maybe don't fuel up properly. They didn't eat breakfast and they took their medication and now their sugar's too low. So we need to have them have a juice and maybe some crackers with peanut butter. So we do watch that very closely and make sure that our patients stay within a normal range. Tobacco cessation. That's huge. Smoking is one of the most preventable causes of premature death in the United States, although a sedentary lifestyle is starting to gain speed on that. Almost 1/3 of deaths from coronary heart disease are attributed to smoking and secondhand smoke. Smoking decreases your tolerance for physical activity and increases the tendency for blood to clot. It decreases that good cholesterol. And it also, the risks are increased greatly if you smoke and have a family history of heart disease. Smoking also creates a higher risk for peripheral artery disease and aortic aneurysm. That big artery can start to have the wall get weak. And it increases the risk for recurrent coronary heart disease after bypass surgery. We actually had a patient who came into our program who had no risk factors at all, except for her husband, who had unfortunately passed away about 5 years before, had been a heavy smoker and smoked around her all the time. So she had unfortunately gained that as a risk factor for herself. So with tobacco cessation, we review smoking status and other tobacco products. We determine the readiness to quit, the stage of change. Are you in pre-contemplation, contemplation, preparation, action, or maintenance? And what can we do to assist you? We connect the patient with a smoking cessation counselor, and we're lucky to have a smoking cessation counselor embedded into our cardiac rehab. And we're able to provide individual education and counseling and pharmaceutical support. And we will assess progress and the stage of change throughout the program. Psychosocial management, stress. Stress is your body's response to change. The body reacts to it by releasing adrenaline, which is a hormone that causes your breathing and your heart rate to speed up and your blood pressure to rise. And these reactions are actually a good thing. It was from caveman days, our fight or flight response. It could get us out of trouble. But the problem with stress, if it's constantly on, we've got chronic stress. It keeps our body in high gear, and then it can cause a problem with our heart. But not all stress is bad, but it's still stress. So the key is you want to manage stress properly. You may be getting married, and you may be buying a new house, and you may be having a baby. They're all wonderful stresses, but there's still stress on your body. Stress may affect behaviors and factors that increase heart disease risk, high blood pressure and cholesterol levels, smoking, physical inactivity, and overeating. So what do? We do a quality of life perception questionnaire for everyone when they come in. We also assess them for depression with a questionnaire. We offer support. The exercise room itself is like a support group. You get to know the people that are in there, and you rally around them and support them through their program as well. And it's a good time to exchange information. And I felt like that 2 weeks ago, but look at where I am today. Nothing speaks stronger than somebody who's actually going through it with you. We have a stress management class that we offer every month at each location. We can connect our patients with a clinical psychologist that's here at Christiana Care. And we're fortunate right now to have an 8-week program that talks about different things that can happen with stress. But what's really exciting is it really focuses on the positives, mindfulness, and our gratitude. So it's an awesome program that we're able to offer that's driven by our clinical psychologist. If our patients are already in treatment, we can communicate with a healthcare provider. Medication compliance is reviewed, and support groups are encouraged. There's Mended Hearts, and there's Women Heart. There's the AICD, the Implantable Defibrillator support group. So there's some wonderful support groups out there. Physical activity, another core component of cardiac rehab. Physical activity is defined as any bodily movement produced by skeletal muscles that require energy expenditure. So physical activity isn't always exercise, but exercise is always physical activity. Physical inactivity has been identified as the fourth leading risk factor for global mortality, and they estimate that it causes 3.2 million deaths globally. There's 4 main types of physical activity. Aerobic, and that's really when you're exercising, you're getting your heart rate up and your respiratory rate up, you're making your heart and your lungs stronger. Those examples are running, swimming, walking, biking. Muscle strengthening, and that is what improves our strength, our power, and endurance of muscles. It's push-ups and sit-ups, weightlifting, stair climbing. Bone strengthening, with our feet and our legs and arms supported by the body's weight. The muscles are pushed against the bones. Running, walking, lifting weights, etc. And stretching, which helps improve flexibility and the ability to fully move joints. So what we do with physical activity counseling is we find out what the recent activity levels have been, what are the individual needs that are for this patient, domestic, occupational, recreational. We typically encourage gradual accumulation of 30 to 6 minutes a day, 5 times a week. And education, our guidelines are for safe, effective exercise, to exercise at home during the program, to incorporate that in, and then to continue exercise after graduation from the program. Exercise training. That is a type of physical activity that's planned and structured. And in our case, we know that it's a telemetry monitored and exercise program. We did discuss our different aspects of our individualized exercise prescription. I do want to touch base though on the volume, that frequency, intensity, time, and type. If you're doing moderate exercise, if you do 30 minutes 5 times a week, that's great. 30 minutes 3 times a week is great. That's 150 minutes. If you do high intensity, if you do 15 minutes 3 times a week, it's equal to what that 30 minutes 3 times a week was. So we do look at that. We always want our patients to warm up first. That's doing some light walking, some slow walking, maybe some light stretches. When they're all done their cardiovascular, when they got their heart rate up and their respiratory rate up, cool down, walk slow, just let that heart rate come back down to normal. Then strength training, maybe 2 to 3 times a week, and then flexibility, which is the stretching. What are the benefits of exercise? Numerous. I won't read all those to you, but there are numerous benefits to exercise. I'm going to go through a quick case study with you, and we're just about done. We had, a few years ago, a 66-year-old black female who came into our program. Her past medical history, she'd had a coronary, a heart stent put in 12 years prior to participating in our program. She had a history of high blood pressure. She had end-stage renal disease. She had sleep apnea. She had had a history of breast cancer. And she had hyperparathyroidism of renal failure. She had a vitamin D deficiency of renal failure, and she had gout. Her story, and what was actually bringing her in this time, is she'd been getting hemodialysis for her end-stage renal failure for about a year. While she was on the renal transplant list, and then about 2 weeks before she came to the hospital, she started getting some chest tightness while being dialyzed. So they sent her to a cardiologist, and he did a catheterization, which revealed that she had what we call triple vessel disease. That means the 3 main arteries of her heart had some blockage. So she did have a bypass surgery. They did all 3 of those, and they even used that big artery in their chest, that left internal mammary artery. But her post-op course was complicated. She was a cardiac arrest when she was in the operating room, and she had a cardiac arrest when she was in the ICU unit. She did manage to go home, but she was readmitted a short while after because she had atrial fibrillation with a rapid response. Her heart was beating very quickly. And about 1/3 of open heart surgeries will have some AFib. So that's not that uncommon. When she came into us, her AFib was under control. So we did some data collection on her. We got her blood pressure. When she started, she was 154/70. When she finished, she was 120/62. We do something called a 6-minute walk test. It's a functional capacity. We see how far our patients can walk, how many feet. When she started, she could walk 150 feet in 6 minutes. When she finished, she could walk 1,050 feet in 6 minutes. We look at METs, that's kind of the oxygen component that is used when you exercise, and she had more than doubled that. We looked at her cholesterol. Her total cholesterol was fine. Her good cholesterol, which I will tell you, and I'm almost done, her good cholesterol had really improved dramatically, and it's hard to get good cholesterol up. She actually went from 33 to 51, which is fantastic. Her bad cholesterol stayed about the same, and her triglycerides were fine. Her weight was not bad when she started. She was 160, but she got down to 147. When we looked at her BMI, she was 22.9, but she improved even more and got down to 21.03. Her waist, she lost 3 inches off of her waist. So that was that body composition I was talking about where she indicated she put muscle on. We looked at her psychosocial score, and she was okay. She was okay when she came in, but she improved dramatically. But for depression, she was very high. She really scored quite high for depression. Not surprising. She had had a horrible course of events, but now she was at a place where she was rebuilding herself. When she left, she almost hit goal at 6. That's phenomenal. And this is a woman who was still waiting for her renal transplant. We looked at her behavior. She was never a smoker. She still wasn't a smoker. Her dietary compliance had dramatically improved, and she was within the range we wanted to see her, greater than 55. She was at 56. And she never exercised before she came into us. And when she left, she was consistently exercising at 500 MET minutes a week, which was our goal for her, at the top of our goal for her. So this is one of many, many, many success stories that we have in cardiac rehab. We have constant success stories. So in summary, cardiac rehab and secondary prevention is a program that looks at the entire patient as a unique individual to create a program that will promote increased physical abilities, quality of life, independence, and confidence. Cardiac rehab provides education and counseling by a diverse healthcare population with specific expertise to ensure that the patient is aware of his or her risk factors and is provided with the tools to manage these risk factors. It is the role of cardiac rehabilitation to empower patients to understand and manage their disease at the earliest stage to stop the progression of the disease. Age should not be a barrier to participation. Both the younger and the older population should be afforded the opportunity to receive the tools to manage their disease, return to a productive and satisfying life, limiting comorbidity issues and impairment of life expectancy. Thank you.
Thank you
Questions?
very much. I've got one microphone here, and there's Dr. Smith with another one. Just a question from me to get things going. You work with a good friend and colleague of mine, Dr. Goldenberg. What's the relationship between you at your degree level and discipline with a physician in treating the patient?
Dr. Goldenberg is our medical director, and he's fantastic. But we're more of the on the ground. We're working with the patients and communicating with the doctor. So we're kind of the eyes for the doctor in the outpatient arena. So we can let him know, I've checked this incision. I have a little question about it. Can you check this out? I've been watching the weight, and it's been creeping up a pound every time they come in, and now they've put on 5 pounds. Can you assess this? So really, we're the eyes and the ears for the cardiologist, for the physician, but they're the ones that are taking care of the patient. So they're the ones that are going to make the decision, the appropriate decision for how the patient should be cared for.
Hello, my name's Sophia. I'm right here.
I don't see you still, I'm sorry.
Why don't you stand up?
Oh, I see you. I'm sorry. I see it.
Hi, my name's Sophia. I'm from Acute High School. My question is, well, you mentioned before, tackling and addressing this issue, finding the early stages of heart disease. But how do you suggest we address the issue of obesity, heart disease, and more in children, so that we don't have to address this issue so much in adults and early stages of this, but rather find it before they get the issue before it starts?
That is wonderful. And if we could do that preventative medicine, that would be ideal. Hopefully, as parents, as role models, we can help to to inspire our children. Unfortunately, it's not having them as tapped in as much as they are, getting them active. I don't know if all elementary schools, I have heard that they have started to pull gym and recess a bit out, so our children don't get an opportunity to be physically active when they're at school. I know that schools are trying to be more proactive and only having healthy choices now at schools for food, but it is tough. That is a wonderful question, and it's a tough one to answer. We really need to address our young people. It's such a disservice because unfortunately, they're not having any symptoms yet, but they're building the plaque up in their arteries now. It's happening. It's going to take until they get a little older before they have an event. But it's sad. We'd love to be able to have that kind of primary prevention that would not allow that to happen. So thank you.
Great session today. Question is, the material that you presented, a lot of good information there. Can it be accessed on the website for Christiana Care?
Oh, I'll have to ask. I'm not sure. I will have to ask to see if that's an opportunity
And
with
the
our.
other question, is there a brochure or something that explains the program?
There is. And I apologize for not bringing it tonight, but I can certainly get some brochures out. I can take your name and I'll mail it to you.
And we'll send out an email tomorrow, and we'll include the website link to DelawareMiniMed.org, where not only last week's presentation, but also this one will be posted online as a PDF. How's that sound?
Great.
And if you want to give us a brochure in PDF form, we can stick that.
That's great. I will do that. Great.
Oh, way in the back, okay,
You have to do all the work tonight, too.
that's fine,
I'll just stand here and look pretty.
you do that.
Good evening, and thank you so very much. Presentation tonight was excellent.
Oh, thank you.
This question is actually directed at the gentleman here in the back.
At Tim.
At Tim. Hi. Hi, Tim. Because of the doctor's guidance tonight on rehabilitation, she had actually pinpointed some subjects that I would like to know if you will be able to bring on board. And she mentioned the stress session. I would like to know if that's something you'll be able to offer in the future. And the other one was, can you bring in something that involves a reversal of cardiovascular heart disease? We know it exists, we experience it, but is there a program or someone who can come in and explain to us if there is a reversal? Can we come back? That is the question.
Dr. Smith, may I please defer to you?
I mean, you can, but I believe what you're saying is you want a class like this on that subject.
That
Right.
is correct.
Right.
Right, and then the reversal question?
I'm not a cardiologist.
Right. That's a, can we do a future program that addresses that as a root cause? Yes. Do you have any comments on true reversal?
My understanding is there may not be, but there can be some slight changes that can cause a bit of a reversal, but not a complete reversal. But I would definitely defer to Dr. Goldenberg in that regard.
Do some homework and find out.
If I can speak about the stress class, we offer a stress reduction class, and perhaps I could send that as well, at each of our locations. And we also have our registered dietitians at each of our locations, and that's open to the public. So maybe we could add that on there. So if anyone is interested, we just ask that you call to let us know to expect you so that we have ample seating, okay? So, good. You're welcome.
Kate, you got one?
Thank you so much for all the information you gave to us today. My name is Wanda Moore. My question is, patients that come to you, that you look at their blood pressure, What happens when a person's blood pressure or the diastolic number, the top number, is way higher than it should be? 150, 160, 140. But the lower number, systolic, is down in the 50s, 60s, 70s. Is that a concern of yours? And the other question I have is about the aspirin therapy. Do you talk to your patients about the side effects of the aspirin? Because from what I've read is there can be some aspirin can actually cause a heart attack if you stop taking it.
Good questions. In regard to the aspirin, we've given an education booklet out, so it does give great information. If we don't touch on the side effects of aspirin, because I can't absolutely confirm that we do, we will actually have that information available within the education packet that we give to each patient. And your first question was in regard to the blood pressure. We don't worry about a blood pressure that's on the lower side. That's where your heart is relaxing. When that lower number is down, that's okay. When that diastolic number is low, that's okay. We don't worry about that. That's just where your heart's relaxing. But we do worry if that top number is high. We're going to want to keep an eye on it and communicate with the doctor where you're at.
Just one thing, as a non-physician, who's repeating what my physician told me in respect to aspirin, don't independently, unilaterally start taking it. That's something for your primary care doc to instruct you to do in terms of dosage and frequency. A lot of people just sort of knee-jerk, oh, I should take aspirin. Probably not a good idea, because there are contraindications. And at this point, it's 1:15, and we've got a speaker that's probably exhausted. So we're going to wrap up now. Thank you very much.